I don't think hospice means death. It's the next chapter.
So now we're focusing on the last 6 months of life.
Legal blood relatives.
You can say, no, I want CPR.
It's
if
not,
you have 5,
that's the messy
that's
part.
the mess part, okay.
Welcome back to another Life Choice podcast. Just wanted to get together. We've had so many folks that have reached out to us over the last couple months coming into the holiday season with questions. So what we want to do is sort of be able to educate and let people know really what hospice offers, but really go through questions that we're getting on a daily basis. With me today is Alex, the CEO and founder of Life Choice Hospice, and our social worker, Sara. So why don't you guys tell us a little bit about yourself and why you really love hospice?
Sure. Well, I'll go first if you don't mind. Joe looked at me, so I am a nurse by profession, and what got me into hospice was really so many different things, and maybe it didn't stick out at first. One of the most pronounced was the situation with my grandma and how she went through her last chapter into death with, not being as comfortable. But so many different things, from being caregiver and being a CNA and being a nurse out there, looking at home health patients that should have been really on hospice. So I really fully 100% believe in the philosophy, and I see the great things that hospice and the hospice team does on a daily basis. So hopefully that answers your question.
Sara, tell us a little bit more about you.
Yeah, I'm a clinical social worker by training. I've been doing hospice for, I think it'll be going on 10 years this January. Time flies. And I also didn't realize why I got into the work, I think, for several years. But thinking about it now is because of my own grandparents and my grandfather specifically. I don't know why he stands out so much. But he was a World War II veteran. I watched him become ill quite quickly. And he did not have hospice services, and neither did my grandmother. Both of their illness came on suddenly, I guess, in my own perspective. But I saw that my family didn't have any support. I think I was maybe around 12. And I remember going to visit both of them in the nursing home and not having the words to describe what the experience was, just having this feeling of knowing that something was wrong, hoping that things could be better. And I think, about hospice today, how it really works to support patients and their families at such a vulnerable time.
I like how you said from your perspective, it came on suddenly from your perspective, because that's how I feel. A lot of these questions are coming from family members, and a lot of these conversations we're having, and sometimes it's hour, 2 or 3 hours, and they say, oh my God, it all makes sense now, going back 4 years, because it started really 4 or 5 years ago. So hopefully some of these questions we could help everyone, open their eyes, see things a little bit better, be able to plan. Bad things are bad things, but if they're not coming out at you suddenly, I think it's a little easier to prepare for them.
Yeah, and one thing, and those are great stories. I think one thing we want to focus on today is because people are calling us on a regular basis, and they're at some of the most vulnerable places in their mind, right? They're sometimes sitting in the hospital, second, third hospitalization, what really to do, and they're calling us with, we need answers. And, one of the things that we looked at is, a few years ago, we looked at hospice and said, it was in the 30%, 40%. It's really came a long way where 50% of the people are dying on hospice. So they're getting some of the care. But the average length of stay for those people is only 18 days. Mm-hmm. So it's less than 3 weeks that you're on service, where it's this all-inclusive service. And one thing that I really looked at is people aren't having the goals of care conversation soon enough, because they hear hospice and they go, death. I don't think hospice means death. It's the next chapter. So I want maybe, Sara, why don't you hit that one first? The goals of care conversation is so important, How do you look at that conversation, and how do you think it could benefit those that are looking for this information?
Sure. I think a goals of care conversation really is foundational to understanding what someone wants or doesn't want. And as a social worker, I really like to start out by asking people, what's been going on with your loved one, right? Working through what's happened up until this point. Going through that narrative really helps me to understand, obviously, what has been going on. But really understanding, how do they feel about it? What has their experience been? What do they define as those challenges, right? Because maybe something that I see from looking at medical records as a challenge isn't something that the family has even defined as a challenge, right? And so maybe my job would be to bring that up gently. Maybe I kind of table that for a further discussion. It really is about having that conversation. What's been happening? I think at the end of the day, when we work to define quality of life for someone, that can go in a lot of different directions. And in addition to that, we're really talking about providing education, right? So what I'm hearing you tell me is you're really tired of doing this, and this, right? It sounds like those recent hospitalizations were really difficult for you, very stressful for your family. If you could, maybe you would want to avoid future hospitalizations. How might that happen? Giving that education, what does that mean? What would that look like? And then kind of waiting for the patient and family to think about that, right? Let's talk about that. Let's talk that through. What would that mean? What services would be provided if we were to do that? Because at the end of the day, I can say that I want anything, but unless I have a means to make that a reality, it's just words. And I think as part of a really strong goals of care conversation, it's about putting some sort of plan into action.
And if I could answer it, I'm going to answer it for a little bit from different perspective. It's not so much as, how to have that conversation, but to your point, right? A survey said that 98% of Americans really want to be at home, comfortable, surrounded by family at their last chapter of life. And, when we started both around the same time. Yeah. That was in a single digits, Yes, we've gone a long way, and we are over 50% now. That's amazing. That's headed in the right direction. The problem is the average length of stay shortened dramatically. And so 18 days is really, truly not enough for me as a nurse to make a difference, right? To connect with the person, to make sure that we've, and it's not enough for people to make all the arrangements, to really get the full flavor of that last chapter, because it's not just about death. It's all that summary of the whole book that you have written. So I really want to just jump back and say, I think the problem is the trigger, what serves. So I think we're doing a good job. We're talking to more people about goals of care conversation, but when we're talking is I feel what the issue is.
Well, let's pause there real quick, because I think the real question is that everyone does have. And we have patients on a regular basis that call us 2 months and they're like, well, I'm not really sure, even if we're saying let's have that conversation. I don't think we're ready, because they associate right when I get on hospice, I'm going to die.
Right.
So let's pause there. When is the time that we should have the goals of care conversation?
Well, here's how it's being. A lot of different hospitals have palliative groups now. So these conversations are being had with people a lot more. Unfortunately, they hold on to it and they have them way too late. And here's what they're trying to do and when they're off. They're trying to say, okay, hospice is for their last 6 months of life, if we had a crystal ball. So now we're focusing on the last 6 months of life. It's difficult because none of us really know. And so the only way that you really know that someone is going to die is close to or at active dying stages. That's when the breathing changes, the heart rate is changing. It's clear a one-way street. You know for sure that person is not coming back to us anymore, and there's really nothing we could do with CPR, with whatever else we're doing. The person just slipping away. So they're having these conversations. Okay, now we're sure patient is going to have less than 6 months to live, and we end up with 18 because some of them we get them right. But a lot of them we see 2, 3, 4 days, and really they don't get much benefit from hospice, except we just coming in, give them morphine, and that's all these other myths are being born from that. So I want to focus, and my answer is, don't focus on what Medicare says, because even we're struggling still with those qualifications. Right. Instead, pay attention to the changes in your life, right? So as we grow in age, you thrive first, and then you kind of have that stable portion of your life, and then you start aging, right? And there comes a point, I would say, focus on few things, right? Like sleep, eating, and multiple hospitalizations.
Before we go farther there, maybe Sarah, you can expound a little bit on there. When you're having, because I know you've had hundreds now of goals of care conversation, what are some of those questions that families need to know? This is what I'm seeing. You hit on a little bit, Alex, but maybe go into a little bit more detail there of like, what are we seeing that you would say something has to change because this is not what the family member wants?
I think a common thing I hear in conversation with families is, the last time they were in the hospital, they were really tired of this. The last time they were here, okay, why were they in the hospital 12 times in 6 months? That's not normal. So what's been going on there? That in itself should be a trigger. There is something going on. But kind of before that, before these hospitalizations, I would even take it as far back as advanced directives, right? Like, do you have those as a social worker? Do you have those on file? What do they say? When is the last time you talked about those? Is the person you appointed still the person that you want on this paperwork, right? These are legal documents. Does this person know what your wishes are? Do these things need to be updated? I mean, I would really take it as far back as that to say, these documents will help to guide your loved one should you not be able to speak for yourself.
So let's go a little bit deeper there because, one is very clinically, and we'll expound on that a little bit. The sleep, being tired, hospitalization. But there is maybe even having that conversation before, like, I'm getting sick, things are happening.
Sure. Let's
have the first goals of care conversation maybe years before hospice is even in the picture to say, these are things that I need to set in place. So maybe, as you were saying, there's, advanced care directives. Many people don't know what those are. Maybe go in a little detail. Sure. If you were to say someone turns 65 today, maybe health is not great, but it's not horrible yet. You want to go in there and say, let's have our goals of care conversation right now. What are the things that you would say there to make sure that they're sort of ready, at least from that front?
Yeah, so we can kind of go into specifics about the different advanced care planning documents. So there's a medical healthcare power of attorney, right? This is a document that's a legal document, and you are essentially appointing someone to act on your behalf for medical decisions if you're unable to do those for yourself. There's many versions of the document depending on where you get it from, and that can really be specified to fit whatever your preferences are. The important thing with the document is, other than completing it, is that whoever you are appointing to make medical decisions for you, if you're unable to make them for yourself, that this person, number one, is going to follow what your wishes are.
That you have written those wishes down.
Knows that you have the wishes down, knows how to easily access this information, and revisit this document routinely. So things change, people change. You did it when you're 65, when you're, 85, 90, or even a year later. I mean, life happens.
It's a true or false question as well. If I wrote my wishes to say I don't want to be resuscitated, when certain things happen, and I said, okay, Joe, you're my power of attorney, and I maybe didn't discuss it with you or did discuss, and you're just like, wow, I'm not following that. A lot of people think that, well, so long as I wrote them down and I have my lawyer sign under that, that Joe is required to follow that. Yeah. And that's absolutely false. Joe can say, now that I'm incapable of making decisions, Joe's going to say, I really don't believe that. My religion doesn't allow me to do that. My ethics don't allow me to do that. And I'm going to say, put them on the tubes, keep them alive. Yeah. And so choosing the POA, I think, is the single most important decision you can do in that document.
And so just coming back there, Alex, will sort of start there. It is really important with that POA and that document to really align those meetings. Because like you said, if I sign a document and I put it in my safe, probably not looking at that because I don't know what it says until later. And someone says, oh, you're my POA. Okay. But it's really putting it on paper to say everyone is under the same understanding.
I wanted to add something to that. Oftentimes we kind of see the other end of the spectrum with a document. Maybe it has been completed, but it was completed.
You may never know, right?
40 years ago. Yeah. And then the patient has selected, I want, all interventions done. And probably they did when the document was completed. The patient is not decisional now. And you're looking at, life-sustaining measures, whatever those are. That is a really heavy burden for any family to have to bear. Mm-hmm. They said that. How could I not follow that? Right. And so that's a real risk that someone is taking by not revisiting the document.
How often do you think you should, again, maybe if there's a drastic medical things happening, that makes you think about that. But how realistically, Alex, you've been in the industry for a while now, how often should you revisit those documents?
I think with every big change in life. So I don't look in life in in years. I really look at it as moments. You hear me say that often too many times. But we've had kids, right? You get married, you have kids. You want to revisit and say, okay, this is what's happening. Maybe my mom doesn't get the money if I die. It's now my wife, and so on and so on and so forth. Well, now the kids are out of the house. It's probably a great time to revisit those. They're in college and what the finances there. Every time that you buy something big or sell something big, I think you should revisit them. Definitely a great point when you get your Medicare card, right? There's a lot of decisions to be made, and one of them should be medical power of attorney, as well as the other documents we're going to get into. But if you get diagnosed with something, I think it would be, if all of a sudden it feels like you're becoming more forgetful, I think there's no such thing as revisiting it way too often. Right, it could only go the other way around. So if you want to do it on your anniversary, if you want to do it on your birthday, all right, let me take a quick look. These documents don't require a lawyer either. That's another misconception. So you could have that and have the witnesses sign and have that in effect. You can update it every year. So no such thing as too often, but definitely with big changes in life, health-wise and financial.
So POA, power of attorney, is one big document. What are some of those other documents that you walk through?
And maybe I may interrupt because we still see most patients don't have POA paperwork. Yeah. So what happens if you don't have any paperwork in place?
A mess. Depending on the situation. So there's a law in the state of Illinois it's the Surrogacy Act. This law essentially states that if you are determined to be non-decisional, that it goes in order of your next of kin. Unfortunately, your next of kin might not be someone that you would ever choose to make decisions for you. But if this document is not on file, things can get very messy. And another, I think, important thing that we've seen is families really should be aware that when we say next of kin, these are legal blood relatives. And I can't stress that enough because I've seen cases where, I am the daughter. Well, you are the daughter and you absolutely have been the biggest support to this person. But in the law, you are the stepdaughter, right? And that has nothing to do with the amazing care that this person has been providing. But, when someone dies, when someone passes away, you, as a stepdaughter, if there's no power of attorney for healthcare on file, you cannot authorize the cremation.
Well, and once the person's alive, you cannot make any decisions, basically. So there is a specific tree, right, of saying, yes. Okay, you don't have paperwork. How does that go? If we can go over it, my wife is not decisional anymore. Who is the power of attorney? Because it's too late to put that paperwork in place now.
Yeah, so it's going to go down the list. I mean, there would be the spouse, there would be the children. It even goes to like siblings of the person, and then it just keeps going down and down and down and down until they're
so spouse, oldest child, next oldest child, and it goes out to the youngest child.
It says children.
Oh, just children. So who,
It's
if
not,
you have 5,
that's the messy
that's
part.
the mess part. Okay, nice.
So basically, and in my understanding, you can deny it. So if I said I'm a sibling and say I don't want that responsibility, or I'm estranged, or I'm not part of their life,
you can definitely say no to responsibility, but you cannot say I want to be responsible for
Correct.
that if you don't have that paperwork.
Right.
So if you, when I encountered this couple, it might have changed. It was the oldest brother, and just like you said, the youngest was in charge, and so the oldest would, we call them, relatives from Florida, not being a part of this, a person for the last 10 years, but now wants to call the shots. Legally, they can. So that's why it's so important to put it in place. But and if these change, they could our audience could look it up by surrogate, Illinois Surrogate Act, and the tree and how that follows. Okay.
Yeah.
What are some of the other documents
There's
that we want to always look at for our goals of care conversation?
There's the POST form,
Okay.
formerly called the DNR form, do not resuscitate or resuscitate. On this document, again.
Physician order of life-sustaining treatment is the new, right?
Yes.
Which no one understands that. So
No one uses the terminology, but the document itself is another legal document in the state of Illinois, needs to be signed off on by a physician. And the document is really listing out, at the top, we're talking about attempt resuscitation or do not attempt resuscitation. I'm not sure if you want to go into
a little bit more,
details.
Sure.
Alex is
It's
better
really
to
just 4
speak on it.
questions. So, I guess so. CPR, do you want, if your heart and lungs stop, do you want your hearts to be pumped, and do you want CPR? So you want chest compressions, somebody on you breaking ribs and doing all that, puncturing lungs. If your lungs stop and you're not breathing, do you want to be intubated and kept alive? So that's the major one. And then it goes into selective measures. So maybe, and I've seen this pretty popular, like I want antibiotic if I get an infection that's curable, but I don't want G-tubes and be fed through my nose and all those other things. So you can go now with a new form, you can go a little bit more in detail and says, okay, this is what I want, this is what I don't. Okay, so I touch base on that. Basically, I want no artificial nutrition, or I want, keep going with the TPN through my vein. There is a middle ground now that says that you could do nutrition for maybe a couple of weeks for the trial period. And that's the one that gets people messy, because that trial period, if you're forced with a big decision, then wouldn't recommend it.
And the only reason I'm bringing it up is this is a big question. One of the first things we say is many people don't know. They just think, CPR. Well, I want CPR. I'm doing good at 65.
Yeah.
Well, when I'm 84 years old and I weigh 116 pounds, do I want someone as big as me jumping on you, pressing your chest?
Right.
And
look at the
causing
percentages,
Right.
Yeah.
20 or 30 more days in the hospital just recovering from that. So it's super, super important for us to really talk about that. So those are like 2 of the major documents. What else is doing?
I want to add something on a CPR. Sorry, because that's touchy. I've had so many discussions on this. And basically in the state of Illinois, Sarah, feel free to correct me if anything has changed. It's been a while. If you have that document, usually we tell you, like, if it's in a home setting, put it on a fridge, put it in a freezer in case of a fire. That's where the firemen go first to look. You have that document, it's an option for you to stop. So somebody in the family calls 911, firemen show up, and you said, no, don't do CPR, because it's pretty graphic. I mean, blood can come through the mouth. I mean, it's really, and the percentages are close to like 1% of success rate. Right. So you need to really carefully think about that. But if you have that paperwork, you can send them out. You can say, no, I don't want it, or you're not going to say it, but yeah, this patient doesn't want it. Here's a DNR. Right. If you have the DNR, but as a POA, you change your mind. You want to say, oh, no, I want my mom to be resuscitated. It's really simple. Put it in trash. Rip it apart. You're the POA. You could even if they've seen it, you can say, no, I want CPR. So really having one gives you an option. Yeah. Not having one, you lose that option. There is no option.
Right.
So, yeah.
Well, I think these are huge answers. There were a couple more documents that we want to go over just real quick. What are those other documents that we try to at least talk about in the goals of care conversation?
I have one, my favorite, But that kind of covers, all of
Financial?
them.
You want to talk about
Yeah,
financial?
again,
Financial,
what are we
okay.
doing financial? And a lot of times we talk about the 5 wishes.
Yeah,
To make sure that
it just covers all of it.
Power
Yeah.
of attorney. Okay, so there is a financial power of attorney that does require a notarization, so people need to keep that in mind. But this document is very important for making sure that you have the authority to act on someone's financial behalf if they cannot do that.
Why is it important to have difference between a POA and a financial POA?
If you need to act on someone's behalf for their financial matters, it's actually called a power of attorney for property, right? So this is any financial transactions. If I need to pay someone's bills, if I need to, I don't know, it's really
Sell a house.
yes, all of those things are. If the person that we're discussing has been unable to make decisions, this will go into effect, allowing them to act on behalf.
And the best setups I've seen is where the financial power of attorney and the healthcare power of attorney are two different people. A lot of times, the son, or it doesn't matter, one sibling will be a healthcare power of attorney, right? Maybe the one that lives in here, but the one that's in a different state has a cooler mind and knows finances better. Yeah. So then, the person decides, okay, I'm going to name my daughter as a financial power of attorney and my son who lives with me as a healthcare power of attorney. And then they both need to collaborate to make things happen and do the finances. So.
It's a really nice checks and balance system.
Mm-hmm.
And I've really seen that work very well. Not just one person has all of the control and
with people who have more estate, a lot of times I've seen financial advisors be the financial power of attorney. Mm-hmm. So it's an appointed person, and they leave them instructions with here's how I want you to treat this, right? Because a lot of times for people, for patients, it's important I don't want you to blow all the stuff that I worked so hard for in my life just on futile, treatments in the end of my life. I want this to be left for my kids, to go donation to a foundation, whatever the case might be. Mm-hmm. And so we've had that cases where sometimes the healthcare power of attorney says, no, but we can afford it. Let's have this other thing. And I said, nope, it hurts me, but I have to follow their wishes. So that's a really good setup. If you don't have that paperwork in place, the financial health power of attorney follows the same tree as the healthcare power of attorney. Is that correct?
I don't know. I've seen it get super messy at that point. Because there's no one who can.
The next of kin, I think the language in the state, the next of kin kind of assumes that responsibility, and it just kind of falls on them.
And again, I just think it becomes really messy because when you're dealing with finances, if you go down that whole surrogate tree, the neighbor that you can say,
it could be a neighbor. We've had that situation.
It could be a close friend. That's
actually
close friend. One of the people on the
and it is on
list.
the list. The problem is that person's not going to be able to say, hey, I need to get in these documents and go to a bank and be like, hey, I'm going to act for Sara here.
Yeah.
You're going to say, well, great, your name's not the last name.
Exactly.
We can't do anything. We need paperwork.
Right.
And if you're at a spot where you can't do that, well, then you're really going to get into a messy situation trying to figure that out. So let's go just real quick into the 5 wishes, which is, again, is part of another document. But again, I always sort of viewed them as separate. So maybe walk a little bit through the 5 wishes.
Yeah, so 5 wishes, it's recognized in over 40 states as a healthcare power of attorney.
I know that it's in 128 languages.
Yeah, in multiple, tons of different languages. The document is, it's amazing because you can go into as much detail as you want about what your actual wishes are, or if you don't want to answer some of those questions, that's okay too. But it goes into great detail on what is important to me and my health, my care, up until, when the time comes that I am dying, what's important to me? Do I want this? Do I want this? Do I not want this? And for those people who really are at that point of having that conversation with their family, their loved ones, whoever it is, having those questions answered can be an incredible gift to give someone when you can't speak for yourself.
So really the document is sort of the guiding light for the POA. So before it was sort of viewed as a separate document. Now it's sort of saying, here's your POA, but again, I can just put it on the paper.
So one of them is POA. So it's 5 wishes. And one of those wishes is, who do I want my POA to be?
Yes.
You know, is there financial as well in there?
No.
DNR, post is that, you know, do I want to be resisted? You have to have in the state of Illinois,
Right.
you have to have a separate post, but it guides you through it on what I want. So if you fill out 5 wishes, again, you can attach some extra paperwork to that, but it's legally recognized and you've got all your bases covered. So like when we have, it's rare still, it's for some odd reason that document is still well-defended secret somehow. And I believe it's paid. We provide it to our patients and we pay for them, but it's $5 and you can get it, as I said, in 128 languages. But that will cover all your bases except post. So you have that document and post, and you're good to go.
Well, you know, this has been super informative just to sort of understand this process. Because as I said, we get people calling in all the time going, I don't know where to start. And, you know, one thing we're really moving toward is let's just get the goals of care conversation going.
Yeah.
Because then we can understand your needs. So I just thank you so much for just all the information that was provided just now.